Between the age of 30 and 70, the average adult loses somewhere between 2 and 4 millimeters of tooth height. And I want you to hold that number for a moment because it sounds insignificant. 2 millimeters, the thickness of a nickel. But those 2 millimeters are connected to the vertical height of your entire lower face. The distance between the base of your nose and the tip of your chin, the resting angle of your jaw, the way your lips sit when your mouth is closed, even the diameter of the space behind your tongue when you fall asleep at night. So the question I want to sit with today is what happens slowly, structurally, over years when those millimeters disappear? Someone I worked with brought in 2 photos, one from about 6 years earlier, one recent. She held them side by side and pointed at her lower face. Something had changed and she couldn't name it. It wasn't her skin. It wasn't her weight. Her cheekbones looked the same. Her forehead, her eyes, all of that was essentially unchanged. But the lower third of her face looked compressed, shorter. The corners of her mouth sat differently. Her chin seemed to flex when she closed her lips, like the muscles there were working harder than they should. She'd been to a dermatologist, tried fillers in her nasolabial folds, asked about a jawline procedure. None of it addressed what she was actually seeing, because what she was seeing wasn't a surface problem. Something underneath had shifted. And at that point, neither of us knew exactly what. So let me ask you a question. When you close your mouth, right now, gently, teeth touching, what determines how far apart your upper jaw and your lower jaw sit? What sets that distance? It's your teeth. Specifically, it's the height of your teeth. Your mandible is a bone that hinges at the temporomandibular joint, up near your ear, and it swings closed until something stops it. The thing that stops it is the point where your upper teeth and lower teeth meet. That meeting point, the occlusal surface, sets what dentists call the vertical dimension of occlusion. It's a measurement in millimeters of how much space exists between your jaws when they're closed. And everything in your lower face is organized around that measurement. Your muscles of mastication attach and function at lengths calibrated to that distance. Your skin drapes over a structure whose height is determined by that distance. Your lips close over teeth whose position depends on that distance. The soft tissue of your face doesn't hang in empty space. It hangs on a scaffold, and the scaffold's height is set by your teeth. So what happens when the scaffold gets shorter? Think about that for a moment. Your teeth lose height through grinding, through acid erosion, through decades of chewing. Not dramatic loss, fractions of a millimeter per year. The kind of change no single dental visit would flag. But over 10 years, 20 years, you've lost enough vertical dimension that the scaffold is measurably shorter. Every muscle that was calibrated to the old height has to adapt to the new one. The skin that draped over the old structure now has more material than the structure requires. It folds, it deepens, it sags. The lips that closed comfortably at the old dimension now require muscular effort to seal at the shorter one. That's the chin flexing, the mentalis muscle straining to close a gap that didn't used to exist. And there's something else. Something I didn't fully appreciate until I started looking at this from a completely different direction. When the vertical dimension of your face decreases, the space behind your tongue gets smaller. Your airway narrows. Not dramatically, not enough to cause obvious symptoms in most people, but enough to change what happens when you sleep. I want to come back to that. But first, I need to address something. The standard explanation for why the lower face changes with age is collagen loss and gravity. And that explanation has real science behind it. Collagen production does decline. Skin does lose elasticity. Fat pads do shift and deflate. All of that is well documented and genuinely contributes to facial aging. But here's a question that model struggles with. Why does one person's lower face collapse noticeably in their 50s, while another person with equivalent skin aging and comparable sun exposure maintains their lower facial structure well into their 70s? If this were purely a collagen and gravity story, the rate of change should be roughly similar across individuals of similar skin type and sun history. It isn't. The variation is enormous. And one of the variables that differs most between those two groups is how much tooth height they've retained. Which brings us to grinding, bruxism. The unconscious clenching and grinding that happens primarily during sleep, though some people do it during the day without realizing, the forces involved are significant. The masseter muscle can generate over 200 pounds per square inch of force on the tooth surface during a clenching episode. That kind of force, applied night after night for years, wears enamel. It flattens cusps. It shortens clinical crown height. And here's the part that kept bothering me when I first started reading across these fields. Why would the body do this? The body protects its structures. Your reflexes pull your hand from a hot surface. Your gag reflex protects your airway. Your pain system exists specifically to prevent tissue damage. So why would the same body that goes to extraordinary lengths to prevent harm command its own jaw muscles to destroy its own teeth with 200 pounds of force? That doesn't fit. That's not a malfunction. Something that forceful, that consistent, that widespread across the population, roughly 70% of adults show evidence of some degree of bruxism. That's purposeful. But purposeful how? Let me back up slightly. I want to start with what happens to your airway when you fall asleep, because the sequence matters here. During wakefulness, the muscles of your pharynx, the tube that connects your nasal passages to your trachea, are actively held open by muscle tone. You don't think about it. The tone is automatic. When you transition into sleep, particularly deeper stages of sleep, that muscle tone decreases throughout the body, including the muscles that hold the airway open. The tongue, which is a large muscle anchored to the mandible, relaxes backward. The posterior airway space, the gap between the back of your tongue and the rear wall of your pharynx, narrows. In a person with adequate airway dimensions, that narrowing is manageable. Airflow continues. Oxygen levels remain stable. But in a person whose posterior airway space is already compromised, and reduced vertical dimension is one of the things that compromises it, that narrowing crosses a threshold. Airflow becomes turbulent. Oxygen saturation dips. And the brainstem, which monitors blood oxygen with extraordinary sensitivity, responds. It responds by activating the jaw muscles. The mandible is pushed forward. The tongue, which is attached to the mandible, moves forward with it. The posterior airway space opens. Oxygen flow is restored. The clenching, the grinding. It's not the objective, it's the side effect. The objective is mandibular advancement. The objective is opening the airway. The body is grinding its own teeth down as a cost of keeping itself breathing. I'll be honest with you, that reframing unsettled me when I first encountered it. I'd spent years thinking of bruxism as a stress response, a tension disorder, something to manage with a night guard and relaxation techniques. And those framings aren't entirely wrong. Stress does increase clenching frequency, but they're incomplete. They describe the modulation of the behavior without explaining the behavior's origin. The origin, in a significant percentage of cases, is respiratory, which means we have a loop. And I want to lay it out clearly because the loop is the entire point. Teeth wear down, vertical dimension decreases, the lower face shortens, the posterior airway space narrows, sleep breathing becomes compromised. The brainstem activates jaw clenching to advance the mandible and open the airway. The clenching accelerates tooth wear. Vertical dimension decreases further. Three completely separate fields of medicine each see their own segment of this process. Dentistry measures the tooth wear, documents the flattened cusps, notes the reduced clinical crown height, and prescribes a night guard. Sleep medicine records the arousals, the oxygen desaturations, the fragmented sleep architecture, and prescribes a CPAP or a mandibular advancement device. Craniofacial specialists measure the reduced lower facial height, the deepened folds, the increased mentalis strain, the retrognathic chin position, and refer to cosmetic intervention. Each field is looking at the same loop. Each field is treating its own segment. The publications exist in separate journals. The conferences happen in separate cities. The clinicians occupy separate floors of the same hospital. And the patient, the person who came in with 2 photographs and a feeling that something structural had shifted, moves between these specialties without anyone connecting the chain for them. That convergence is what stopped me. Not any single finding, each one is well established within its field. The tooth wear data is solid. The airway physiology is well characterized. The cephalometric measurements of facial change are reproducible. What's missing isn't evidence. What's missing is someone standing far enough back to see that these 3 bodies of evidence are describing one continuous process. Your teeth are getting shorter, your face is following them down, and your airway is paying the price. And the price your airway pays drives the grinding that makes your teeth shorter. So let me take you back to the person with the 2 photographs. Once the vertical dimension loss was identified, not the skin changes, not the volume depletion, but the structural shortening driven by decades of nocturnal grinding, something shifted in how we approached her situation. A properly fitted occlusal guard intercepted the grinding forces. Not a generic pharmacy guard, a lab fabricated one, designed to maintain her existing vertical dimension and prevent further loss. Over the following year, her sleep quality improved measurably. Not dramatically. She wasn't someone with severe apnea, but the micro arousals decreased. The morning jaw tension that she'd assumed was just how mornings felt began to ease. Her face didn't reverse its changes. Bone remodeling and muscle adaptation don't rewind on their own, but the progression stopped. The photographs from the following year looked like the same person. Not younger, but stable. The lower face had stopped compressing. The before and after here isn't a transformation story. The jaw angle didn't dramatically sharpen. The nasolabial folds didn't vanish. What changed was the trajectory. Before, she was on a curve of progressive structural loss that no filler or procedure could address, because none of them were targeting the origin. After, the curve flattened. The architectural loss stopped accelerating. And the principle underneath this, the one I'd want you to carry out of this conversation more than any specific protocol, is about how you listen to your body's compensations. Grinding isn't a disorder to silence. It's a sentence in a language your body speaks when the airway is under pressure. Jaw tension in the morning isn't a stress symptom to meditate away, though stress does amplify it. It's structural information. The face you see changing in photographs isn't purely a skin story, or a collagen story, or an aging story. It may be in part a dental architecture story, one that connects your teeth to your sleep, to the shape of the space you breathe through every night. The question worth asking isn't only how do I stop grinding? The deeper question is, what is my body trying to protect when it grinds? And if the answer is the airway, then the intervention that matters most isn't the one that stops the grinding. It's the one that addresses why the grinding was necessary in the first place. 2 to 4 millimeters. That's where we started. A measurement so small, your dentist might not mention it. But you understand now what those millimeters carry. They carry the vertical height of your lower face. They carry the geometry of your airway. They carry the quality of the sleep that either maintains or destroys them. They are not cosmetic. They are structural. And they are, quietly, one of the most consequential measurements in your body that almost nobody is tracking. I walked you through 3 fields today: the dentistry, the sleep physiology, and the facial biomechanics. And I tried to show you where they converge on a single process that most people experience, but very few understand. If any of that gave you a new way to look at your own face, your own jaw tension, your own sleep, I'd ask one thing in return. Share the idea with someone. Not the video, the idea. The next time someone mentions their teeth are wearing down, or their jaw hurts in the morning, or their face looks different and they can't explain why, tell them about the loop, the vertical dimension, the airway, the grinding. That conversation might be the one that connects the pieces for them the way no single specialist visit has.